be able to have a conversation today with Dr. Steve Novella, who is a physician neurologist in practice at Yale. And I've got some questions for you, Steve, about how we, my colleagues and I, as mental health professionals, can best be of help to our frontline healthcare providers, the doctors, the nurses, the respiratory therapists, and all the other frontline providers who are caring for COVID-19 patients.
Mm-hmm.
So if we could start with, I'd love to get your perspective as a physician. What do you see as the major challenges and stressors that frontline providers are facing now as they're caring for COVID-19 patients?
Yeah, and I'm not personally caring for COVID-19 patients, but a lot of my colleagues are, and I may be at some point, depending on how overwhelmed the system gets. Some of my fellow neurologists have been pressed into duty, as it were, taking care of COVID-19 patients, and we probably haven't seen the worst of it. So, but speaking to a lot of my colleagues, some in New York, some like really in the worst places where the surge of COVID-19 patients is the most. I think there's mixed responses to that. I think what I'm seeing is a lot of equanimity. I mean, I think physicians are ready for this. This is kind of what we're trained for. We step up to the plate when it's our time, and I think people are just knuckling down, doing the work that they were trained to do. But yes, it's extremely stressful. I think the most stressful things that my colleagues are complaining about are not having the resources to do their job, right? It's like, yeah, we'll do our job. We'll put ourselves at risk. We'll take care of patients. We'll do what's necessary, but just give us the tools to do it. And so like not having the PPE, the personal protective equipment, is very frustrating. Not having enough ventilators to go around is extremely frustrating. And that frustration, definitely dramatically increases the stress levels that they're experiencing. And then, of course, no physician wants to face that situation where we're making life and death situations about patients, especially based on pragmatic considerations, not medical considerations. Yes, sometimes patients die despite the fact that we did everything we could, everything that we medically have the technology to do. You sort of learn to accept that as a physician. But when patients are dying because we don't have the resources to give them the care we could give them, it takes a much, much bigger emotional toll, and I think puts a lot more stress on those physicians.
Oh, that makes a lot of sense, Steve. And those kinds of moral challenges where a physician or a nursing professional or another therapist has to make a decision who gets the care, who gets the ventilator, who gets the treatment. I'm sure these are situations that every healthcare provider knows could happen. But my impression is that these kinds of choices are now facing healthcare providers on a much more frequent basis. And the stakes are incredibly high.
Yeah, in the hardest hit areas, definitely, it's the most common description I get is it's a zoo, it's chaos. Now, essentially, they're in the worst hit hospitals. They're just trying to triage like who has COVID-19, who doesn't, and try to get the sickest patients into the ICU. One I think very concrete example of how our resources are being stretched is that in some hospitals they've actually approved a protocol where 2 patients can be serviced by 1 ventilator. I've never heard of that before in my career, 2 patients on a single ventilator. That is, I think, a good concrete example of the desperation that we're in these hardest hit locations. But also I think of physicians they're kind of pragmatic. It doesn't just get the job done, do what it takes. So that's kind of an innovative way to address the shortage of just, figuring out some way that 2 patients can share a single ventilator. But it's not an ideal situation. Nobody wants to do that. You have to synchronize 2 patients breathing, and it's not a great situation. So it's, you're layering the not only just the medical challenge, but then the sort of political challenge, the idea, the pragmatic economic challenge that we're facing. And physicians are people too. We come home to our families. Again, I'm not treating COVID-19 patients, but I do procedures that are considered essential, and so I'm still going into my clinic and seeing patients physically, and we're doing everything we can in terms of like obsessively washing hands between every patient, wearing masks and visors and cleaning all surfaces. But we also know even when you do that, you can still get it. This is a highly infectious virus. You could be perfect, pristine, and still get it. And then that puts my own family at risk as well. And that is very, very difficult. I know for those people who are like in the ICU treating multiple COVID-19 patients, they're not going home. They're just living at the hospital, or the hospitals are making available apartments for them so they could live there for the duration that they're doing inpatient care, which adds another layer of isolation and stress to the whole thing. It really puts you out of your comfort zone. You get into a groove. Yes, it's okay to work hard, but then you have your support structure that enables you to get through the hard work. But then you take that away as well, and that adds an additional layer of strain.
So the impact on the frontline provider, there are just multiple layers. I want to definitely come back to talking about the impact on personal life, but what I'm hearing from you, Steve, is that there's the additional burden that's created when frontline providers have to improvise, when they have to be incredibly creative, when they have to do without the adequate supplies or without enough equipment. And they're very creative in doing that, but that's a lot of extra work. And then in doing that work, it sounds like, there's always the question of, is this going to be as effective? This is not our typical procedure. This is not how we use a ventilator. We don't do 2 patients on a single ventilator. So is this something that's going to be safe? Is it going to be effective? Then that concern for the patient's well-being and welfare, and even for the patient's life, that's another layer. And then on top of that, there's the concern, what am I being exposed to as a frontline provider? Am I now at risk? How much of an impact is this going to have on me? Am I taking on a very heavy viral load by this constant contact? And then another layer yet of, when I go home, am I bringing this home to my family? Am I inadvertently putting my family members at risk? And what I heard you say that I think is really crucial is, it sounds like in all of that, it's almost impossible for frontline people to find a way to just step back and reset.
Yeah, I think all of that's happening in the context, I think, of baseline, psychology of healthcare providers. In order to get through nursing school, medical school, all of that training that is required, you have to romanticize the difficulty of it to some extent. We all do that. We talk about the fact that we do that. We say, "Oh, you're going to be working 100-hour weeks," as if you're scaring, prospective medical students or doctors out of it. But that just romanticizes it. It's like, yeah, I know, I'm going to be working so hard. But the reality of it's always a little different, But I do think it sort of helps us get through it. It's like, yeah, this is the profession. This is what we do. But at the same time, I think that could lead to sort of ignoring or maybe minimizing the actual stress that it's causing. And I think one of the difficult things that physicians may have a hard time doing is admitting that the stress is getting to them, right? Because we're not supposed to do that, right? We're supposed to just tough it and brave our way through it. That's sort of the nature of the job. And that is reinforced through every step of our training. Suck it up and do it is kind of the mantra that gets you through your residency. Therefore, you're now facing these multiple layers of stress. And I think the final layer is that you can't admit that to yourself or to others that the stress is there and that it's wearing you down without, on some level, it kind of was entrained into you that that's a failure in some way. And we don't like to be failures.
We know from the mental health perspective that what you can't admit but that you are experiencing is going to eat away. It's going to, if not hurt you, it's going to wear you down. So I think you hit on something really crucial. And I was wondering also, in with this pandemic and the kind of invisible enemy that now healthcare providers are facing and their patients, it's as if the myth of invulnerability that you were just describing, that's cultivated in training, is just pretty much pushed aside. I mean, you can't be invulnerable if you don't know when the enemy is present, if you don't know where it is, if you don't even know exactly what it is, except that it's there once you see the symptoms, and at that point it's already in some ways too late. So
yeah, I mean, I don't know that the infallibility thing is that big of an issue, to be honest with you. I mean, I know that that's sort of conventional wisdom, is that physicians somehow have to think that they're infallible, but that gets beaten out of you early on in your training. Where you have to grow comfortable practicing medicine in the absence of perfect knowledge, because we never have it. We're always making decisions with the information that we have, and we're applying general information to specific individuals, right? That's the art of medicine, is applying the data that we have in unique situations. Without ever knowing what the absolute correct answer is. You're just sort of playing the odds always, just with the best information you have. It definitely is very it's very nice. We love it when we're in a situation where we have a lot of information and we can be very confident in our decisions. That always feels good. And it's also stressful and frustrating when we are in a situation where we lack information, and we're trying to manage a situation where we really don't know what's going on. That's to me personally, that's like the most stressful thing, is when I have to make decisions and I really just the information isn't available. And I mean, it may be beyond just not having it in an individual case. Like medical science doesn't know the answer yet, and yet I'm supposed to come up with a plan in the absence of actual real data. That's really, really difficult. So here we're dealing with a pandemic. It's happening in real time. It's moving very quickly. We know we're always a couple of weeks behind what's actually happening. And it's a novel virus. We don't really know everything about the virus. I think that gets magnified by the fact that society is experiencing the same thing, and handling it in the way that society does, which is every possible way, some good, a lot bad. So we're also dealing with patients who are particularly fearful, patients who are maybe full of misinformation, who are being sold snake oil and pseudoscience, and so we're trying to deal with that as well. We're trying to give out information with the correct amount of confidence, being sure that we include the caveats about what we don't know, and then counteracting the inappropriately confident misinformation that they're being fed from other sources. So it's a lot of balls to keep in the air to try to manage, not only just the medical issues, but also the public perception about what's going on.
And given the complexity and the rapidity with which things are changing, at the end of the day, how do you as a physician and your healthcare colleagues, how do you judge whether you've actually been effective?
So, well, I think the easy thing with an acute illness like this is the outcomes are fairly immediate. This disease takes about 2 weeks or so to play through, and patients by then will be on the road to recovery, or they will have died. I mean, that's basically what's going to happen. So we're getting immediate feedback in terms of what we're doing and what's happening. It's as opposed to, say, chronic illnesses where it's years, of presiding over an illness, and it could be really hard to know if you've been nudging it in the right direction or not. So that there's an immediacy to this, which does actually help a little bit, but at the same time, you don't really know. I mean, it's tempting to listen to your own anecdotal experience, but we all know as scientists that that's highly misleading. We have to listen to the data, but the data is lacking. We don't really have it. And so we're sort of going with our clinical experience, knowing how flawed it is, but it's the best we have until we can gather, more reliable scientific data. So again, we're just sort of making do with what's at hand, knowing it's inadequate, and just doing the best we can and hoping for the best.
And you mentioned the larger public. A crucial segment of that larger public, it's all important, but perhaps especially crucial are the families of the patients. And I wonder, what's your sense of how has dealing with and trying to be of help to families, how has that changed in this pandemic?
Yeah, so you're always treating not only the patient but their family, and oftentimes, that dynamic is critical to understanding the patient's presentation and also to managing the patient. Conventional wisdom is that for every additional person in the room, when you're talking to a patient about what's going on, and that they'll collectively they'll remember an additional 10 to 20% of the information that you give them. So we actually like that. One of the single best predictors of good outcomes medically is a close support structure. So having a family support structure or an extended support structure is critical. It's actually more stressful when there isn't that in place, like a patient doesn't have a support structure, and then it's hard, again, from a practical point of view, it's very hard to really take care of patients when they don't have that. Mm-hmm. So I think it's, families are a net positive, definitely. But in a highly, highly contagious illness, you really have to worry about the extended, ecosystem that the patient is in, because you're not just treating the patient, but everyone that they come in contact with to some extent, and so you have to deal with that as well. Again, we're all under stress. The family's going to be scared. They're going to be looking for information, and you're going to encounter the entire range. Like we do in real life, like we do just with anything, from people who are fairly, well educated and reasonable and will listen to you, to people who are distrustful of the system. They haven't had good encounters in the past. They're maybe full of misinformation or have their own sort of philosophies of medicine that they have to contend with. So that could present a lot of challenges as well. That's kind of, in my practice, my regular outpatient practice, that's what I spend a lot of time dealing with, but I'm dealing with more chronic, less urgent issues where patient and family education is pretty much our most important tool. Here, you're dealing with an acute illness where decisions have to be made quickly, and there isn't as much time to manage, perhaps long-standing perceptions among the patient or among the family. So again, that could add to a lot of stress. Like you can't very, very quickly fix a dysfunctional social structure when you're dealing with an acute, potentially fatal illness. You just have to make decisions and do it. So it's it's always a mixed bag, but I think in the end, having a good family support is a huge positive thing. But with an infectious illness, you have to think of the extended contacts of the patient as well.
And I was wondering whether it might not present an additional challenge for the healthcare providers when they have to tell the families that they can't be with their loved one.
Yeah, so that's a very common theme that we're hearing, and I'm hearing that not only from providers but because we all now know people who know everyone knows someone who died of COVID-19 now. There's enough patients who have died from it, and I have multiple people in my extended connections who have relatives who have died from it, for example, or who have it and are battling it. And that's the single most consistent complaint that I hear is that I can't be with my loved one when they're dying, when they're on a ventilator in the intensive care unit, and I want to be with them and I can't be. And that is incredibly stressful for the family and for the loved ones. And that is hard, again, that's another thing that we have to deal with as healthcare providers, because we're often the ones saying, you can't do it, you can't come into the ICU, it's for your own good, it's for everybody's own good, but it's very hard. But, I think people understand it. I haven't heard of or encountered a lot of pushback against that. People know you have to isolate people who are infected, but it's just very stressful and makes people very, very, cranky and fearful, and just adds to the overall stress.
And I would think that for the families, and I'm saying this because of the impact on the provider too, that so much of what they're experiencing, it may take the form of frustration or impatience or desperation, but it's fundamentally grief, because there's always the prospect that the loved one will or may die. And then I'm wondering if the grief that the families are experiencing, how that impacts on the provider.
Mm-hmm.
We have a phrase in the traumatic stress field, secondary traumatic stress, where
Mm-hmm.
providers are affected by the traumatic stress of their patients. In this case, it's traumatic grief, and it's the family members who are experiencing this profound sense of not just separation, but literally grieving and not being able to be with the person as they are trying to say goodbye, as they're trying to grieve. I can only imagine how difficult that would be, not only for the families, but also for the providers who are right there and have to, in some ways, be the intermediary in place of the family.
Yeah, that's sort of an emotional dance that all professionals do as well, because we're trained as professionals to have a certain emotional distance, but at the same time, you have to have a therapeutic connection, a real
Mm.
emotional connection to your patients. You have to care, but not so much that you are deeply emotionally affected yourself. So you have to make a connection but keep just enough distance so that you're not, adversely affected. Your ability to make calm, rational, detached decisions is not
Mm.
affected by that. But we're all people, right? We are affected by it. As much as we try to keep that professional distance, and we can from a pragmatic point of view in our decision making, it emotionally affects us. Nobody wants an unhappy patient. Nobody wants to be that like the worst moment for any physician is telling someone that a loved one is dying or has died, or telling a patient that they have a horrible disease. I mean, those are emotionally just wrenching moments, but we have to be very stoic throughout, because we are sort of the strength that we're going to try to lend our strength to the patient, to the family. So that's everyone's different, of course. Every
Mhm.
physician is, we all bring our own personality and emotions and everything to our profession. But as a general rule, I think that's always an incredibly stressful situation.
Mm.
And yeah, so that I think that. And you could see that in the professions that deal with that more have a higher burnout rate. It definitely takes its toll on physicians. So my concern with something like, the COVID-19 pandemic, it's taking a year's worth of that stress and compressing it into a month or two,
Right.
because it's all happening one after the other, after the other, after the other. And then what happens to that healthcare provider who's dealing with so much concentrated, emotional stress that they normally, will have it, can space it out, get over one before they have to address the next.
Hmm.
And so I think that's probably going to be a source of a lot of, again, the shared trauma or the shared stress of the providers. It's just so concentrated.
Mm. And that compression, then, it would seem that it would challenge anybody, even with the best
Hmm.
training, even with the hardiest uh, personal characteristics and strengths, to not just become somewhat numb, and at the same time, perhaps to also just never quite be able to feel like they can let down their guard, that state of
Yeah,
vigilance.
yeah. I mean, it's a balance that we all have to find what works for us based upon our pre-existing personality and characteristics, etc. Some people intellectualize more. Some get, I think, cynical and nihilistic. You
Mm.
can distance yourself emotionally by being cynical, but I don't think that ultimately works, long term. I don't think any of my colleagues really have experience in this kind of situation. I would imagine that the an analogous situation would be like a wartime
Mm-hmm.
medic, where just the concentration of trauma that you're seeing is so intense. But of course, we know that takes a huge emotional toll and burden as well.
Mm-hmm.
So I'm not comparing this to a war situation in terms of how horrific it is, but just in terms of the compression of dealing
Mm-hmm.
with the intense emotional situations with patients.
Mm.
It shares that feature, which I think can be very, very draining, very difficult to deal with.
And we know that the impact on healthcare providers who are medics, who have served in war zones and in combat situations, it's It's very, very intense, and they're incredibly strong and resilient, and yet it still has a very profound impact over time. So now we have not hundreds or even a few thousand medics and frontline surgeons and nurses working in a combat area, but we have tens and hundreds of thousands of healthcare workers. So it seems as though the magnitude of the effect, even though for each individual they're coping and they're handling things in a way that's often incredibly resilient, it's just such a broad spectrum. It's not just a small group, relatively small group, but this is pretty much healthcare providers across the whole spectrum, all throughout the entire world. So now, given that, given the scope and given the intensity of the impact on frontline providers, what do you think mental health providers can best do to help in this immediate crisis period? How can we best be of help to our frontline colleagues?
Yeah, I think it's hard to give any general rules because again, everyone is individual and they might their needs are going to be different. But I think like one thing that comes to mind is that it's telling healthcare providers that it's okay. It's okay to be stressed. It's okay to feel overwhelmed. It's okay to feel frustrated or a little bit out of control. I am, extremely proud of all of my colleagues. They are, as you say, as a profession, extremely resilient. And I've seen that. I've seen when they're discussing it, they're like, "Yep, this is what we got to do. This is what it is," and they just do it. And they do display incredible strength, selflessness, and resilience. And it's one of the things I'm really proud of my own profession. But I do think that underneath that, there is a lot of stress, a lot of emotional wrenching going on. And, if just being told it's okay to be under stress and to acknowledge that to yourself and to also to take steps to look after yourself, whether it's taking a day off or taking a break or whatever, doing that is good mental hygiene. It's not a failure. It's not letting other people down. It's taking care of yourself while you're taking care of others. So we tell that all the time to our family members of patients, right? I say all the time, like every, severely chronically ill patient has a family member probably who's taking care of them. And I almost always at some point have to tell them, how are you doing? Are you taking care of yourself? Are you getting time off to look after your own needs? Because you get so absorbed in taking care of somebody else, you can let it grind you down because you feel guilty about doing something that's for you. And I think the same would apply to healthcare workers. I think especially as this pandemic drags on, the thing that's interesting is we're right in the middle of it. We don't know how long this is going to last. What's this conversation going to be like if we're getting a second wave in the fall, or if we flatten the curve, but it just keeps on going and going and going? After months of doing this, I think we really need to make sure that we are having a sustainable policy, right? That healthcare workers are meeting the demands, but in a sustainable way so that they don't start to grind down under the constant pressure of having to take care of so many patients.
This is clearly not a sprint, even though obviously for each provider, there are many, many moments where they are literally sprinting, just trying to keep up with the situation when a patient goes critical or when there's a major dilemma. But the marathon aspect, so I've also heard frontline providers say that, yeah, I know I should take care of myself, and I know that self-care is important. I got to put on my oxygen mask first. I've got to step back and make sure that I can replenish so that I have the energy and strength. But I feel completely disloyal, not just to my patients, but to my colleagues, because they're still working. How can I possibly step back and not do that and leave them without the support that they need from me? What do you think about that as a dilemma? Is there any way that we can be of help with that beyond simply letting them know that it is really crucial to be able to replenish?
Yeah, I think it's easy to fall into self-imposed guilt and shame. And I think any profession that focuses so much on personal responsibility, which medicine does and we have to have a very, very high degree of personal responsibility on many ways. So it's kind of already built into the system that we are going to impose that onto ourselves. But that's where I think just that the permission aspects comes in. That first of all, it's to some extent it's intellectualizing. It's like, yeah, I get it. You want to feel responsible. You don't want to let your colleagues down. You don't want to let your patients down. But just intellectually, you need to take care of yourself, or you won't be able to keep up the pace that this pandemic is requiring. And also just to give people the permission to say what they need and do what they need, so that they will remain high functioning and won't buckle under the strain of what's being imposed upon the system, upon all of us.
And it seems as though it's really crucial for healthcare providers across all professions to be a role model, to set a standard and to set a bar. So I think it's really interesting and important that you're saying, that acceptance that one needs to step back and one needs to be able to sustain for the long haul, that actually that's another way in which healthcare providers are role models for their colleagues, not just by doing the incredibly hard work and staying with it and withstanding the stresses, but also by being willing to do maybe what's harder sometimes, which is to actually step back and reset and restore themselves.
But I do think, and again, I have a limited perspective like anybody. I haven't surveyed all of medicine, but in my 30 years as a physician, I think things are very different now than they were at the beginning of my career, and that just institutionally and just professionally, I do think there's a lot more support from within the profession for physicians and healthcare providers. Back in the 90s when I was being trained, it was more the suck it up and work hard and don't complain. And now it's much more of a nurturing, I think, self-nurturing environment. So I do think we're in a much better place as a profession than we were in the past. It's certainly at the beginning of my career, in terms of recognizing that, physicians need to be nurtured and supported, and they need time off, and we have to look after our own mental hygiene as well. So I do hear from the powers that be within the hospital, within the system, that concern as well. So we are here to take care of patients, but while we're doing that, we have to take care of ourselves, because otherwise we're not going to be able to sustain this effort. And so I do, I think as a profession, we're doing a much better job of that than we have in the decades past.
Do you think that mental health providers can help their frontline colleagues, whether in a debriefing situation or in a therapeutic session? Do you think that the mental health providers can help healthcare providers on the front line recognize the contribution that they're making, and without just it being shallow or artificial praise or compliments?
Again, I think there's a lot of individuality there. I do think just talking about it is extremely helpful, and talking about, the good things that you're doing, talking through the things that you're feeling in terms of having to deal with the pragmatic challenges that are in front of you, and maybe complaining a little bit about the stressors or what's happening. All of that, I always find that extremely useful. Just vocalizing, verbalizing what I'm internally thinking and feeling. And part of that is, taking credit for the hard work that you're doing, I think is bolstering. So I think all of that can help tremendously.
And what about the families? Because I wonder if in the short run, they're doing everything they can to support their family member who's on the front lines. And that's a strain for them as well. They're worried about her or his safety. They're worried about their own safety, their children's, their elders. In the long run, I wonder, how important do you think it's going to be for mental health people to be prepared to help the families who have been affected, along with the healthcare providers themselves?
Yeah, I think, as I was saying before, like any healthcare professional, even mental healthcare professionals, you're always treating the family and the patient, right? The patient is embedded in their family as the most important support structure that they have. And so that has to be addressed almost always as a whole. It's hard to pull like the patient out of the context of their social, their family support structure. So I think it's very important, to address how are you dealing with your family? How are they feeling about everything that's happening, about its impact upon you, upon them, upon, your time together? Is it keeping you apart, et cetera? So I can't imagine how you wouldn't address that along with, everything that the individual professional is experiencing.
So let's wrap up by give us a little bit of guidance. What should mental health care providers be careful not to do? What are the mistakes we could make in attempting to be help for our frontline colleagues?
One of the pitfalls you might want to avoid is, like telling physicians that you don't have to work so hard, or, something that would maybe downplay, the dedication that they're bringing to what they're doing. It's like, we know that, what we're doing is hard work. We know that there's risk involved, and we're choosing to do it, right? We chose this profession. Those who are on the front line are choosing to be there. And don't second guess, I would say, that choice or downplay its significance. I would just say, respect it and understand it, but just deal with the implications of those choices. Because, we have reasons for making the choices that we do. It's part of our identity. It's part of our professionalism. It's part of our career now. It's who we are. So I would say just make sure that you don't inadvertently disrespect the identity of the physician, of the healthcare provider, and the choices that they made that brought them to where they are.
And I would imagine it's probably important, but tell me if I'm wrong, to also not try to step in and tell the healthcare provider what they should be doing for self-care, as opposed to inviting the healthcare provider to consider what they feel are the best ways to take care of themselves, to care for their families, and to have a solid personal life.
In this situation, like, again, I'll extrapolate from my own experience. I actually love treating my fellow physicians because I can communicate to them in a very efficient way, and I bring to that therapeutic relationship an understanding of where they're coming from because they're a fellow professional. And so I can parlay that, I can leverage that into the therapeutic relationship. So I would say the same thing probably would hold true with mental health providers and other healthcare providers. We're all health professionals. So what we're about, you have some insight into us professionally because you are fellow professionals. And so you could leverage that as well. So again, you don't have to necessarily tell us what to do so much as get us talking about what we already know we need to do, and so to give us permission to do the things we kind of already know that we need to do, or maybe help us think it through and come to our own conclusions, which from my understanding, again, I'm not a mental health provider, but from my understanding, that's pretty standard anyway in a therapeutic relationship, is to not give advice, but just to help lead people to insight that will help them make better decisions.
We all want to believe that everyone in the mental health profession knows that. But I think it's wonderful to hear that from a neurology physician colleague.
Well, my wife is a therapist, so I get a lot of it from her as well.
Okay, good. One last thought I just wanted to run by you, Steve, and that is, what do you think mental health providers can do over the long term to help physician and nursing and other healthcare providers who are experiencing not just the sense of stress and frustration and all the challenges that go with just being caught up in this nonstop, rapidly evolving crisis, but to help them to be able to mourn some of the losses that they've experienced. Because I would imagine that even though, as you said, healthcare providers, physicians, and others are really prepared for the fact that some of their patients will not make it. Death is part of life, and it's part of the practice. But there is so much death now. As you said, we all know someone who knows someone or someone directly who died. and it's happening so fast and in a volume. I've heard residents say that they've experienced more death in the last 2 weeks than they had over 3 years of their residency, just as one example. Given the intensity of the losses and the deaths, I wonder how much do you think grieving is going to play a role in the healing longer term for frontline providers?
Yeah, I mean, listen, we all grieve and mourn for our own patients in our own way. And again, that's part of that balance between having a professional distance so that you can do this, you can live your life dealing with so much, so much loss and so much death. But at the same time, still maintain that emotional therapeutic connection. And so everyone, from my perspective, it's very individual. And again, that's the kind of thing, I don't think there's a formula for like, this is how you grieve as a physician or as a healthcare provider who's dealing with so much death. It's more like, you tell me how do you typically deal with this? How do you grieve? And just get the professional thinking about that process so they're not just burying it down for now until it comes out later. Again, this is a marathon. They need to pace themselves. They might need to process their grief along the way. But I think that's one of my concerns about the intensity of this pandemic, and the fact that it's compressing so much that we have to deal with into such a short space of time. There really isn't time to process the loss of one patient before you're moving on to the next. So how do you deal with that? I think what I've seen in some of my colleagues is that they just increase the distance. You just can't process it. So you can't get as emotionally invested in each individual patient because you don't have time. And it's and I know this is a described phenomenon where you emotionally distance yourself from someone in anticipation of the loss to try to blunt the impact. And so physicians do that with patients as well. We sort of emotionally distance ourselves from patients that we know we're going to lose. But I don't have experience with it so intense as what we're seeing during this pandemic. I imagine my colleagues who are on the front line, many of them don't have that experience either. So we're kind of figuring out as we go along. So I think as a mental health provider dealing with that, the first order of business is just to figure out how are they dealing with it? How do they typically deal with it? Rather than trying to impose some kind of formula on them, just get them thinking about it so that they're not ignoring it and letting it fester.
That's a great point, because what you don't think about will fester, will build up. What you do think about can be painful, can be difficult, and sometimes there's not time to do it at a given moment, as you said. But at some point, what you need to distance yourself from probably is exactly what is most impacting. And finding the way that the individual physician or nursing professional or respiratory therapist, finding or helping them find the way that works for them to be able to just acknowledge that impact and do whatever grieving they need to do at the time when they're able to do it. Well, thank you, Steve. This is, for me, as a mental health provider, this has been extremely enlightening. You've given me a lot to think about, and I am now feeling better prepared, not fully prepared, but I think this is going to be exceptionally valuable for many of my colleagues in the mental health field, and thank you very much.
Oh, well, thank you.
And best wishes for your safety. Be careful when you're on the inpatient rotation or when you're on the COVID units. I hope that you're very safe and healthy as well.
Oh, thank you.